Good morning, everyone. First of all, thank you, Marcello, for inviting me to participate in this meeting. I'm very happy to be here today to talk about some of our work on biomarkers in mitochondrial myopathies. First, I have to say that I am a clinician and adult neurologist, and I am specialized in genetic myopathies in general, but with a particular interest on those with metabolic or mitochondrial origin. And is there where our group is involved in some clinical research. These are my disclosures. And here's the agenda. I'm going to walk you through some of the biomarkers we're studying in our cohort of patients in Hospital 12 de Octubre here in Madrid. Specifically, I'll talk about creatine kinase, lactate, creatinine levels, GDF15, and some words about the muscle MRI and the mitochondrial DNA analysis we are doing in the muscle. So primary mitochondrial myopathies are mitochondrial diseases with a special affection of the muscle, of the skeletal muscle. And therefore, the muscle symptoms are the only, or at least the main clinical manifestations. Patients may present with predominantly exercise intolerance, with chronic fatigue, muscle pain, and episodes of acute muscle injury, such as rhabdomyolysis episodes. But patients may present with predominantly ocular myopathy, with chronic external ophthalmoplegia that can be either pure in isolation or in combination with skeletal myopathy or extramuscular features, the PEO plus syndromes. And finally, some patients, this is more rare, may present with progressive muscle weakness, mimicking other genetic myopathies or muscle dystrophies. This is the patients that are more difficult to diagnose, although these patients also may have some ocular involvement with ptosis or partial ophthalmoparesis, and also they may have some extramuscular involvement. Therefore, the best way to define the primary mitochondrial myopathy phenotype is such as continuous clinical spectrum from muscle pain and fatigue to chronic progressive myopathy, weakness, with or without ophthalmoplegia and with or without extramuscular features. So there is a huge clinical overlap and a huge clinical variability in patients with PMM. And in addition, we also have a huge genetic heterogeneity. And we can have variants in both the nuclear genome or the mitochondrial DNA genome. And altogether, this makes it very challenging to design clinical trials for this population. And there is an urgent need to identify a common biomarker that correlates with the severity of the disease that can be used in clinical trials as an outcome measure in patients with PMM and different phenotypes and different underlying genetic defects. And in our group, we are doing a natural history study. This is a cohort that is a prospective study. It's still recruiting in a single center, just in 12 de Octubre Hospital, and with the same personnel that are attending the patients. And now we have at least 77 patients with predominantly neuromuscular involvement, especially primary mitochondrial myopathies. And in these patients, they are all adult patients, and they have 36 mutations in nuclear DNA, 13 in POLG, dominant or recessive, 6 twinkle, 16 TK2 deficiency. These are the group that don't receive treatment and treated TK2 patients. We also have another cohort that are receiving nucleosides. And 41 patients have variants in mitochondrial DNA, 26 single large-scale deletion, and 15 different point mutations in mitochondrial DNA. And all of these patients have almost a pure myopathic phenotype. The clinical distribution in this cohort is, as you can see here, the more frequent phenotype is the ophthalmoplegia plus phenotype, followed by the ophthalmoplegia pure phenotype, but there are also a big group of patients that have progressive muscle weakness. The less frequent phenotype is the group with isolated exercise intolerance. What we do in these patients is we see them every 6 months. at the clinic. We are trying to doing a 3-year follow-up, but probably will go on. And every 6 months, we do a neurological examination. We assess the strength using different measures. We assess the strength manually with the MRC strength score evaluation, but also we do a functional motor function scale, which is the North Star Laboratory Assessment, and also different time tests, such as the 6-minute walk test and the 100-meter run test. In my experience, this last test, the 100-meter run test, is the best and most sensitive to capture all the muscle problems in patients with PMM. We also take samples for analysis of biomarkers, such as creatine, kinase, creatinine, lactate, and GDF-15. We also do a respiratory assessment once per year, and also an annual muscle MRI. And also, all patients, all of them, do have a muscle biopsy for the diagnosis, and the majority of them have agreed to repeat the muscle biopsy with a needle, just to analyze the heteroplasmy levels, but also the copy number in the muscle, and also we use the mitosalt to look for the profile of the multiple deletions in patients with maintenance disorders. So it's a small cohort, but it's a very well-characterized group of patients. I'm going to focus just on biomarkers. First, CK activity. You know that is the marker of muscle damage that is used more commonly, although unspecific. And it's known that in patients with mitochondrial myopathies, it is generally low. It's not very high in comparison with other muscle problems. But in our cohort, it was increased in 56% of the cases, almost, but only moderately, with a mean of 412 units, and was significantly higher in the group of patients with exercise intolerance and also in the group of patients with TK2 deficiency. However, CK levels don't correlate with muscle function or with the overall severity. Lactate levels, which is the best-known biomarker for OXPHOS dysfunction, is very useful when it's altered because it's very helpful for the differential diagnosis to point toward a mitochondrial myopathy. However, it lacks sensitivity. In our cohort of patients, it was increased in 42% of the patients, but only very slightly, with a mean increase of 2.8. And we did not find any differences in these levels regardless of the genotype or the phenotype. This is more interesting, the creatine phosphocreatine system, which serves in the cell to store and shuttles energy. We know that creatine is an abundant protein in the muscle tissue, and it correlates with the muscle mass. Creatinine is the degradation product of creatine, and in the blood is used to assess the renal function, so a very easy marker to test. And creatinine is also related to the muscle mass of the patients. And in our cohort of patients, the majority of them, 65% of them, had low levels of creatinine. And many patients with normal CK levels have low levels of creatinine, so it's much more sensitive to detect muscle involvement in a patient with PMM. And more interestingly, these levels correlated strongly with the motor performance of the patients. They were significantly lower in patients with muscle weakness, and it correlated also with the function test we do to assess the motor evaluation. Here I show you some of these graphics that show that how creatinine levels correlate strongly and significantly with the 100-meter run test. It also correlates with the North Star Ambulatory Assessment, and it's helpful to distinguish in which patients there is muscle weakness and, more important, muscle involvement among the whole cohort of patients with PMM. Regarding the GDF-15, GDF-15 is a cytokine that is induced in the muscle due to the OXPHOS dysfunction and was first described more than 10 years ago in a subgroup of patients with TK2 deficiency, in a transcriptomic analysis in patients with TK2 deficiency. Since then, multiple cohorts have been describing the high sensitivity of this biomarker to diagnose patients with mitochondrial diseases in general, but it's more sensitive in those patients with muscle problems. But it's not widely used in the clinic. We, in our center, use GDF-15 quite commonly because we found that it's very sensitive to distinguish in which patients with muscle problems there is a myopathy of mitochondrial origin as an underlying defect. It's, despite the genotype, all in mitochondrial DNA variants and nuclear DNA variants, the GDF15 is very useful to distinguish which patients do have a mitochondrial myopathy among patients with muscle symptoms. And this is true even in patients with very mild symptoms, patients with fatigue or muscle pain. There are many patients with chronic fatigue syndrome or fibromyalgia that are referred to our clinic with the suspicion of mitochondrial myopathy. And in these cases, the GDF15 is very sensitive to distinguish which one do have a mitochondrial myopathy. And we use it to select in which patients we do a muscle biopsy or further genetic analysis. In our cohort of patients, GDF15 was increased in 90% of the cases, so the more sensitive biomarker of all of them. And the only cases with normal GDF15 were those with a pure ophthalmoplegia phenotype. The mean increase was almost 3,000, which is threefold the normal value, and we did not find any differences in GDF15 values based on the phenotype or on the genotype. So it was increased significantly in all phenotypes and genotypes. So very sensitive and useful in the differential diagnosis and to diagnose a PMM patient. But more interestingly, these GDF15 levels in this cohort correlated strongly and significantly with lactate levels, which is a biomarker of oxygen function, and it also correlated with the heteroplasmy levels in the muscle. So it suggests that the higher the oxygen function, the higher the GDF15 levels. And in fact, I told you before that creatinine correlates very well with the motor performance. Well, here GDF15 also correlates very well with creatinine levels. All of this suggests that GDF15 can be used also to predict the severity of the disease and to monitor the disease progression. In fact, we have studied GDF15 in more detail in patients in the subgroup of patients with TK2 deficiency, and in these patients, we found that it correlates strongly with the overall severity of the disease. In fact, GDF15 correlates with the age of onset. Patients with a very early onset rapid progressive disease with TK2 deficiency do have an increase of GDF15 of 60-fold, while patients with a late onset disease do have a 6-fold increase in GDF15. So there is a very strong correlation between the levels of the biomarker and the age of onset and severity of the disease. And in fact, within the group of late onset TK2 deficiency, all adult patients, GDF15 also correlates with the severity of the phenotype. It correlates with the motor performance. I show you here the correlation with the North Star Ambulatory Assessment, but also with the 100-meter run test. As you see, this test is the more sensitive way to capture the muscle problems in patients with PMM because we are analyzing and capturing not only the maximal effort of the patient, but also the endurance of the patient. And in these cases, GDF15 also correlates with the respiratory involvement, with the forced vital capacity. So a very good biomarker to assess the overall severity of patients, at least in TK2 deficiency. And you know that there is now a new treatment for TK2 deficiency, which is the nucleosides therapy. And in the patients that start treatment with nucleosides, GDF15 falls down. It decreases significantly over time in parallel with the improvements, with the clinical improvements, and even it normalizes when the patient responds the most. So it's a very good biomarker for the diagnosis, to monitor the disease progression, and also to evaluate the response to treatment. So in my opinion, this is a good candidate for clinical trials, at least in the population of primary mitochondrial myopathies. I'm going to briefly talk about the muscle MRI. This is a tool that is used a lot in the field of muscle problems, but not very much used in the field of mitochondrial myopathies. In a muscle MRI, you can see in the muscle, when it degenerates, it is substituted by fat, and you can see how it gets atrophied, and also it increases the white in the muscle, which is fat. So you can't see the degeneration of the muscle. And in different muscle diseases, there is different muscles that are affected, and you can see also the degree of the alteration of the muscle. And we have found that in TK2 deficiency, there is a consistent pattern of involvement in the muscle MRI with an early alteration of the gluteus maximus muscle and also of the sartorius muscle. This pattern is different from other genetic myopathies, but it's also different from other mitochondrial myopathies. And in fact, this is very useful in the differential diagnosis with other muscle problems with similar clinical characteristics. But not only that, we are now analyzing the data of our cohort of patients with PMM in general. We found, again, the pattern characteristic of TK2 deficiency, which is different from the rest of the mitochondrial myopathies. We are now trying to analyze which muscles are more useful in the differential diagnosis to try to be able to identify different patterns of different genotypes. This is still ongoing. But more importantly, this degeneration that we see in the muscle MRI, we can quantify it objectively. We can quantify, using a software from the MRI, which is the Dixon sequence, the amount of fat in each muscle. This is called the fat fraction. And this is a very objective way to track the disease progression. And this fat fraction, very importantly, correlates strongly with the motor performance. We see that in other genetic myopathies, but also in mitochondrial myopathies. There is a very good correlation with the strength measured manually, but also with the 100-meter run test. You see here this correlation, which is quite strong with the gluteus maximus. I said you before that creatinine was the best predictor of the muscle degeneration. Well, here you see the good correlation between the creatinine levels and the fat fraction in the gluteus maximus. So these two tools are the best way to assess the amount of muscle involvement in patients with mitochondrial myopathies, and also useful to track the progression of the disease over time. Now, just a few information about the analysis of the mitochondrial DNA in the muscle. We are doing calculating the heteroplasmy levels in the muscle in patients with mutations in mitochondrial DNA, but we are also analyzing the copy number, the total amount of mtDNA in the muscle in different genotypes, not only in the maintenance problems, but also in patients with mutations in mitochondrial DNA. And we are also assessing the profile of the multiple deletions. Well, the first thing we saw is that if we compare different maintenance problems, those with a TK2 deficiency are the ones that have lower levels of mitochondrial DNA in the muscle, despite the age of the patient. So patients with a late onset disease do have significant low levels of mtDNA in the muscle. This is quite important because we see that the impairment of the nucleotide pool has a huge impact on the synthesis of the mitochondrial DNA, more than the alteration of the polymerase gamma. In fact, in patients with POLG, there is only a mild decrease of the mitochondrial DNA in the muscle, and there is a trend to have lower levels in patients with recessive genotypes than in those with dominant genotypes. This is some data that we'll talk in another occasion about the profile of the mitosalt, which is different in patients with TK2 deficiency, Twinkle, and POLG. We are comparing not only the profile of the multiple deletions, but we are trying to compare with the amount of mtDNA, which is this figure. But also in the subgroup of patients with TK2 deficiency, where we have studied this the most, we saw that the amount of mtDNA in the muscle is the best predictor of the prognosis of the disease. We saw that the amount of mtDNA can predict the age at onset of the disease and also the age at onset of the mechanical ventilation. So if you do a muscle biopsy during the diagnosis and quantify the amount of mtDNA, you can predict the prognosis of the patient. And in fact, there is a difference in the amount of mtDNA depending on the genotype of the patient. We know that there is a milder genotype, which is the deletion of this lysine in the position 202. And in this milder genotype, we know that the amount of mtDNA in the muscle is significantly higher. So the best way to predict the prognosis of the disease. We can maybe use this when there is a screening, neonatal screening of TK2 deficiency to predict which patients need the treatment earlier. And with that, I'd like to conclude with some relevant points. In my opinion, GDF15 is the best biomarker we have to the diagnosis, to the differential diagnosis, but also to monitor the disease progression, to predict the severity of the disease, and also can serve to monitor the response to the treatment, at least we know now in TK2 deficiency. The creatinine levels, which is very easy, cheap way to test, and in all analyses we have the creatinine levels, is the best biomarker to predict the amount of muscle degeneration in patients with primary mitochondrial myopathies. The muscle MRI is an objective tool that is useful in the differential diagnosis, also useful to monitor the disease progression, and also correlates strongly with the motor function. So also useful to select patients in clinical trials and also to monitor the patients in those trials. And finally, we are still studying the mitochondrial DNA copy number in muscle, but we can say now that it can predict the prognosis, at least in patients with TK2 deficiency. And with that, I'd like to thank you all for your attention.
That was outstanding. Thank you very much. Dr. Mancuso, if you'd like to come up, we could ask you both questions. I'd like to start with Dr. Domínguez. So I loved your use of the MRI. We often look at the leg MRI, and sometimes we see fibrosis rather than fat replacement. So I wonder if you can comment on your selection of which muscle you look at and whether you see fat or fibrosis. And then my other question is, if the muscle body has been replaced with fat, you would expect the mitochondrial DNA amount to be lower. Is that correct? And is that a correlation you've seen?
Well, first, these are all adult patients. In patients in children with myopathy, the MRI looks quite differently, and it is at least known in different genetic myopathies. In the mitochondrial myopathies, I don't know if children have been tested. So the fibrosis, it's more common in patients in children, in kids, than in adults. So with that, we can only analyze fat. We don't know if there is also, it should be fibrosis, but we can only analyze the fat. And it's true that the amount of mtDNA also correlates with the amount of muscle. So we always, in our analysis, we always do the muscle biopsy in the same place to try to avoid these discrepancies, but it has to influence, of course. And in our patients, we do a muscle MRI of the whole lower legs, from the pelvis to the feet. And the utility depends on different muscle diseases. In mitochondrial myopathies, at least, the more useful muscle to assess is the gluteus maximus muscle, is the more affected in general in all patients with mitochondrial myopathies, but we test the whole the whole legs.
Wonderful, thank you. Are there any questions in the audience? Dr. Prakash, here.
Thank you. Yeah, I also want to say it's a very nicely characterized cohort of patients with muscular myopathy, and I was wondering, do you see differences between non-mitochondrial myopathies, so from the markers which you can use in mitochondrial disease and non-mitochondrial disease? Do you have same markers of progression or completely different?
Well, GDF15 is very sensitive to mitochondrial myopathies. It is not increased in other genetic myopathies. Creatinine, it is also used in other neuromuscular diseases. For instance, it has been used as a prognostic marker in patients with ALS and also in patients with Duchenne muscular dystrophy. It also is able to distinguish patients with Becker and Duchenne muscular dystrophy, which is Becker is milder. So it has been studied in other genetic myopathies, but not in all of them. And in not all myopathies, it occurs this. I mean, I follow a lot of patients with genetic myopathies, and not all of them have low levels of creatinine despite the degeneration of the muscle. So there is also a component of a metabolic component that we still don't understand.
Because if you focus on the muscle, you don't necessarily, and you focus on TK2 patients, you don't necessarily need a marker which is specific for mitochondria. No? It can be any marker which shows you the progression or predict the progression of the disease. So it doesn't need to be a mitochondrial marker. That's why I'm asking. Maybe there's outside of the field of mitochondrial diseases, there's something which is better.
Yeah. The muscle MRI is used in all the muscle field. We use MRI, and the fat fraction correlates with the motor function in all the diseases that has been studied. So it's not specific for mitochondrial myopathies. But I don't know that it's widely used, the muscle MRI in this field. But in other genetic myopathies, it is. Yeah.
And what is the time window of progression? So how long do you have to follow the patient to see really clinically relevant differences?
We are studying this because our study is prospective and longitudinal, and we are analyzing how the different motor function measures changes over time. We see that the more sensitive way to detect this deterioration is the 100-meter run test. And we are analyzing the amount of fat fraction that increases over time, but we are still doing this. We still don't have enough data, but we are working on that.
If I can ask another question. So, because we have seen a lot of 6-minute walking tests, and you do.
I hate that test. Yeah, if you're asking me about 6-minute walk test, I don't like it.
This was my guess, but I.
I don't like it.
And do you have a 100-meter long floor in your department, or how
Yes.
do they run 100 meters?
We have a very long, ¿cómo se dice pasillo? Floor, corridor. Yes, we have it. Yeah. The 6-minute walk test does not ask the patient for the maximal effort, so he has to just walk. So it varies a lot in every visit in patients that are treated or not treated. It varies, but by a lot. It's different if you ask the patient to run, then he has to make all the effort he can, and it's more consistent every visit. So I use 6-minute walk test because always they ask me for this result, but I don't like it. And in our test, the correlation with the motor function is much more stronger in the run test than in the 6-minute walk test, but by a lot.
So now I have to ask Michelangelo, what do you think about the 6-minute walking test?
I don't know. We all think the same, yeah. But I mean, unfortunately, most of the regulatory agencies are in love with the 6 minutes, so you must take it.
Not anymore.
Yeah, but so far this was the story. Yeah.
Thank you. I was going to say not anymore. Marnie and I and Michu as well were in the workshop recently, and we talked about the 6-minute walk, and they understand and agree that it's not the best way of moving forward. And looking at all the newer programs that are in trials now, they don't have the 6-minute walk as an outcome measure, which is good.
One thing Dr. Zolkoply-Cunningham, who's our neuromuscular specialist, has noticed in the adults and the children is that there's a difference in endurance in mitochondrial myopathy that sets it apart. So if you don't look at the total distance over the 6-minute walk, but you look at the minute-by-minute distance, you see a degradation over time. Do you see that?
I mean, in Italy, we also have published this in the, if you check the slope between the first and the 6 minute, the difference is significant, yeah, in PMM. I don't know what's your experience, but.
Yeah, so maybe that's the better way we should use the data, if we have to use the data.
Just the last intervention I made, because I know that you are enjoying the discussion, but also you would like to enjoy lunch and coffee.
Okay.
Then we have to...
Quick question. So as an adult geneticist, I do see a lot of fibromyalgia and chronic fatigue syndrome patients. And I just wanted to ask you, because in my hands, the GDF-15 is often elevated in these patients because they also have autoimmune diseases. They might have diabetes or some other condition that will elevate their GDF-15. And I noticed in your plot there's an overlap between the mito cohort and that. So is there a cutoff that you use for GDF-15 to say, no biopsy for those, no further, it's just chronic fatigue fibromyalgia?
Well, we use the cutoff levels that the kit provides that differs depending on the age of the patient, and all the patients that are above this cutoff, we do a muscle biopsy, because if there is a mitochondrial myopathy, the muscle biopsy would be pathological. In our experience, all patients with a mitochondrial myopathy and muscle symptoms have rugged red fibers. So a patient with fibromyalgia, even some of them can have some mild CK levels increased. In all of them, we do a muscle biopsy finally.
Okay, thank you to all the speakers. And please go enjoy your coffee. And thank you, Marcello, Genomit, and the patient advocacy group here in Madrid for the invitation.